Dr. Reem Al Shaikh. We are live. Hello and welcome again
Hello.
to the Menopause Research and Education Fund. And today we're talking about hearts.
We are hearts and all things heart related.
Exactly. So before we get into it, let me give you a quick introduction. You are at the Women's Wellness Clinic, and I've actually forgotten where that is. Where is it? Where are you actually?
So we are based in Cambridgeshire and Bishop Stortford and Ware. We're also in it, and so that's myself and my partner in crime, Dr. Gillian Shields. So we offer menopause care, whole women's health, and I'm also an NHS GP partner.
True, and not only that, you have a diploma in gynecology, and you've also done the Faculty of Sexual and Reproductive Health. Why do I have feedback here? Faculty of Sexual and Reproductive Health stuff. And let me move that away. Let's see if that helps. I've got a bit of feedback.
No problem.
In fact, actually, what I might do is turn that off and see if that helps. And you are a menopause specialist as well. I do have feedback. You know what I'm going to do? I'm sorry, I'm going to fix it here on Instagram because I think that might be the problem. And just let me try this one more time and see if it connects. To get rid of. Hang on a second. Are we both 1, 2, 3, 4, 5? I don't know why I've got feedback. All right. Let me turn this off. I'm sorry, guys. Can you come here afterwards? We'll jump in. I think that might be my problem.
All right.
You stay there.
I'll stay here.
Yeah, that's fixed it. So, or has it fixed it?
I think so. I can hear you.
Yeah. All right, good. That's all right. Then it's yeah, that seems to have solved it. Good. All right. So it was in. So we are talking heart health. Sorry about that. And the reason why we're doing that is because around menopause, as you well know, we have these silent changes that creep up on us that that cause our cholesterol to change. It causes our triglycerides to change and our blood pressure and all of those sorts of things that we have no idea about that are going on quietly in our bodies. So I guess the question is, why? What are each of these major things and what happens to them when around menopause in particular?
Okay, so I think what should we start? Let's start with when we go through perimenopause and menopause. I think we all know that our estradiol level starts to go down. So that's the estrogen hormone, the female hormone our ovaries make. It starts to drop, things start to happen, and really annoyingly, to some extent, they just start to go wrong. So what we know is that as we lose our estradiol, our cholesterol level, in its basic terms, starts to go up. But not just our cholesterol, our LDL-C, our low density lipoprotein, the cholesterol that actually we don't want to go up, starts to creep up, which can increase problems in our blood vessels. Our triglycerides also start to go up, and we see this a lot. So I see this a lot as a GP when I'm doing women's just general bloods for whatever reason. And you start to look at their trends and you see that over years their triglycerides and their LDL are creeping up, and they haven't changed anything. They're eating the same, they're exercising the same, but we see this due to the loss of estrogen. Triglycerides are something people don't really talk about, I think, necessarily in the kind of public sector that much, but it's an independent risk factor for coronary heart disease. So you don't want great big high triglyceride levels either. And we know that our HDL, the kind of good stuff, really annoyingly starts to go down as we lose our estrogen. And estrogen is an anti-inflammatory hormone, so we become more inflamed when we don't have it. And our endothelial function gets a bit messed up. And that's the way that the best way to describe it is our blood vessels aligned with muscles and cells, and effectively everything malfunctions when we don't have estrogen. This is really important because this is the beginning of the kind of issues that women start to get when we think about what kills women worldwide and it's heart disease. And I think it mustn't take away from the fact that when we talk about hormones and HRT and everything we like to talk about on this channel, we do think a lot about the cancers associated with hormones. And breast cancer is really important, and I do not want to belittle it at all today, but heart disease kills women. It's the #1 killer of women worldwide. And it's mad that there are multiple signs as we age that it's coming our way, and we're not always very good at acting on them, specifically as women, the women ourselves, and we're not good at acting for women as healthcare professionals. We're kind of relaxed. We let these things happen. We also have this kind of other issue when we lose our, pardon?
We still have this kind of perception, really, that it's sort of like, oh, heart disease, it's a man's disease.
Yes.
All of the pictures are always men with the chest.
Yeah. In the movies, if you think of a heart attack, just image, be a man going, collapsing, really histrionic. You also associate it with smoking. So don't get me wrong, I don't want you to smoke, girls, but it is not just a disease of smoking. So women get blood vessel changes as they age. And so all the kind of normal things that everybody kind of might believe affects heart disease, so smoking, being very overweight, drinking heavy alcohol, yes, they all can contribute to a woman getting heart disease. But just being a woman and going through menopause contributes to heart disease.
Yeah.
And that means 100% of women or persons with an ovarian system are going to have to think about their heart health, even if they believe they're doing all the lifestyle stuff really well.
Yes, exactly. Because I don't think people also realise that by the time we reach 65, we have the same heart attack risk as a man. I mean, you always think it's ages away. Yeah.
And it's not. And I actually think, look, I've been a GP for 20 years. I don't think women come into my office ever, never worrying about their hearts. And when I see them having gone to the A&E department with symptoms that sound worrying, I cannot tell you how often I get that letter going, no diagnosis, non-cardiac chest pain. Now, don't get me wrong, that could mean there's 100 other reasons why they had that pain, but it is so often not looked into when a woman presents in the emergency services with symptoms that honestly are classically heart related, let alone the ones where we get symptoms, that aren't necessarily the big ticket items that people think about when they think about their heart. But we don't necessarily present like men. We sometimes do, but we don't really understand what's happening to us. And our disease is often different to men. I'm kind of jumping maybe a little bit forward here, but there's lots we need to be thinking about tonight. We want to get women kind of really thinking about their heart health and understanding why it's quite important to be aware of themselves.
Exactly. So, but before we get to those things that sound like a lovely holiday destination, like Inorca, Anorca, Minorca,
Yeah.
I mean, they sound like the Royal Islands, but
That's
they
funny.
are not. Before we actually get to them, let us go back then to the three main things that do change: the blood pressure, the triglycerides, and the cholesterol that you mentioned before. And what should people be doing then to make sure that they've got this under control?
Okay, so let's do you mentioned blood pressure. So our blood pressure, just as a factual comment, because a lot of women watching this might be on HRT, the HRT is not affecting your blood pressure. I don't want anyone stressed about their blood pressure if they're on hormone replacement therapy. But our blood pressure can just go up with age. You may have underlying genetic risk factors for having high blood pressure. You may be doing everything right in your lifestyle and think, why is it high? Because there's a genetic underlying risk factor. Our weight goes up. It's crap, but it's true. So we go from being very pear-shaped when we've got lots of estrogen knocking around. Our fat distribution really preferences our butts and our hamstrings and our quadriceps. Our powerhouse muscles are really preference for fat distribution. As we go through menopause, the way our fat is stored annoyingly changes. There's loads of factors for this. One of the big ones is lipoprotein A changes, and it affects the way our fat is stored. But effectively, we go from being nice and pear-shaped to having more fat around our organs. That's visceral fat, that's bad fat, we get more central adiposity. And there's, again, multiple factors why that happens, but loss of estrogen is a big one. And so we get this
belly now actually wobbles. I can feel it lying in bed at night, sitting on my leg.
It's so interesting. I had a yoga instructor recently who's like, I'm amazing. I'm exercising all the time. I know exactly what to do. Where's this belly come from? And she was sort of in her late perimenopause. And this is all the fat distribution changes that she can't necessarily easily control. You can do things to kind of support it, help it, improve it. But the reality is it happens without you realizing it. So we get this change in fat, we get this unhealthy brown visceral fat that can also contribute to insulin resistance. It can contribute to fatty liver disease. It makes us more inflamed. Being more inflamed can put your blood pressure up and cause all sorts of other problems. So I think what I would say with regards to what we do is realistically, from your mid-30s onwards, you might want to consider getting a baseline cholesterol done. Where am I? In the NHS, we do free health checks from the age of 40 every 5 years. And it's focused on really basic things. What's your weight? What's your height? Do you smoke? Do you drink? Let's do your cholesterol levels. Let's look for type 2 diabetes. It's worthwhile and it's free. Your practice may not be offering it, but you should go.
Yeah. It's probably too young because these other changes. I mean, this is the argument about saying, we should have a 40+ check. But if these changes
early.
At 50 or so, then you're being told by the time you turn 50, you will have forgotten about all of this.
That is true, but your medical record won't have. So what helps me is having a trend. And you're right, turning up at 35 or 40, more than likely, unless you carry some genetic underlying drama, your bloods are going to look good. It's not going to be different. You're not going to be seeing the problems arise. But actually what we see over many years is changes and slight incremental increases in these cholesterol levels that make us go, what the heck is going on here? Now, to some extent, being really aware of your perimenopause, what's happening with your estradiol, your estrogen level is really important, because that's where the conversation around can you choose hormone replacement therapy depending on your situation becomes a really active conversation. It's really interesting. We know multiple randomized controlled trials and large-scale Cochrane review. We're talking about really best level evidence is telling us that we know if we commence hormone replacement therapy within 10 years of our last menstrual period, that actually we can prevent cardiovascular damage and disease, providing we haven't really developed it at that point. So don't get me wrong, if you smoke 40 a day from the age of 20, no amount of HRT is going to undo that damage. But we know that hormones promote heart health and reduce all-cause mortality. That is a humongous statement. It reduced death from all causes, but it's complicated and nuanced because we all know, based on multiple conversations, not every woman can choose hormones or will choose hormones or suit them for whatever reason, because the hormones we prescribe are not ours. They're made in a laboratory. Mother Nature's not stupid. They're the best we have. So I think what we need to start kind of really thinking about is the fact that we know hormones promote heart health and support heart health, but there's many things we can be doing to consider our heart health as well.
The interesting thing about that, though, is when we say we know that HRT is good at preventing heart damage in the future, but it's not recommended as a primary or even a secondary preventer.
Yeah, why is that?
Yeah.
Exactly. Interesting, right? So don't you find that fascinating? I do. It comes back to, okay, why not, right? So why not? When we look at studies around heart disease, heart attacks, women are wildly underrepresented. I think we are like about 30% or less of the participants of all data that we have worldwide on heart disease and strokes. That's just mad, right? So we do present with different types of heart disease. In fact, I don't know if this is a moment to maybe jump into that, but men often have true obstructive blood vessels.
Yeah.
So heart attack, you stick a catheter in their leg, you go up all through the vessels, make your way through the roads, and there's a great big obstruction. And you stent it and you fix it. That's classical what people, I think about when they think about someone who's had a heart attack, if they think beyond just the pain and the problem. But women present, so, women do get that, don't get me wrong, but women often get microvascular changes, or not even, they don't have obstruction at all. So when you go in and you look, they may have had a heart attack. And we know that because the blood test associated with heart damage is high. They presented. These are the minoccas, the ladies going to that holiday destination. Myocardial infarction with non-obstructive arteries, meaning we've gone in, there's no obstruction, but she's had a heart attack. That woman could have microvascular disease, or she's got spasming. She actually lost her oxygen blood flow to a bit of the heart that caused that significant event, but it wasn't because there was a blockage at all. It was because actually there was a temporary spasming of her arteries, her blood vessels. And when I think about trying to describe this to patients, I say, look, a big coronary artery blockage is like the M25, right? Big obstruction on the M25. But women often get obstructions on the B roads and the dirt tracks that don't show up on Google Maps. So there are multiple roads in the system of roads. There's multiple blood vessels in our system. And
or as here in London, we probably call them the rat runs.
Yeah, it's the really small ones that women seem to get problems in, and therefore it's often not diagnosed correctly. And there are many ways to diagnose this in women. When you're in that catheter lab and there's a tube up that woman looking at her heart, they can do things that stress that woman's heart there and then to look for spasm. They can give a special drug that causes stress. They can do tests of resistance to just work out what's going on. That doesn't happen. I'm telling you, like, I see my patients, it doesn't happen. And then they should, if it doesn't happen, go on to do these really fancy non-invasive tests like stress MRIs. We look at the vessels, we give the woman a drug, we cause stress to the cardiovascular system in a controlled environment, and we try and understand what is happening to her so we can best treat her. Because just saying there's no obstruction, or you've gone to A&E and it's not obvious, you didn't have a rise in troponin, which is this protein that our heart throws out when it's got heart damage. That is an indicator of a heart attack. If you go to A&E as a woman, you don't have the obvious things, you are often sent home and not investigated further.
Yes, and I think it's the Heart Foundation put out a thing basically saying, please stop using the words non-heart related pain, because basically all of the things are being missed.
We don't know what it means. It's just a made-up term. And what it really means is no one found a troponin rise. But that doesn't mean it's not a heart problem. And it's really interesting. You brought up the British Heart Foundation. They have a great document about bias, about gender bias. So I think the headlines of that are, we are misdiagnosed. So when we show up, we're often 50% of the time not diagnosed correctly as women. But we're also our own worst enemies, because we do get chest pain. So I think there's a misconception. Don't get me wrong, we'll talk about the other symptoms, but women do present with chest pain. They often do, but we ignore it because we assume I'm stressed, I'm tired, I'm like, I've got to sort out whatever I've got to sort out. I'm too busy to pay attention to this. Oh, I'm a bit breathless because of some other problem, because I'm a bit fat. And that's probably why I can't walk up the stairs at the moment. And so we start to kind of weave tales. We give ourselves a narrative that it can't be our heart. And I don't know how to undo that. We have to start getting women in the mindset of heart disease kills women, #1 killer of women worldwide. Therefore, if your chest hurts, you should be thinking about it. And it's hard until I tell you it's not. And it's starting to get into that mindset of, I don't want to freak everyone out. Because the other problem, as we're going to chat about, is that women sometimes present feeling a bit sick. They get palpitations, a sensation of their heart beating. They're achy. Maybe it's a bit achy. So I feel a bit achy. I feel a bit panicked. And culture has it that if you walk into an A&E department as a woman at a certain age, looking a bit stressed out with your panic, you will be misdiagnosed. And you will collude, because they'll go, you seem stressed. And you'll go, yeah, I'm bloody stressed, right? Because most of us are. And they'll go, did you sleep well yesterday? No, I bloody well didn't, because I'm menopausal and I've got sleep disturbance, but I didn't sleep well yesterday. Oh my God, that's probably made it worse. And you start to kind of get into these stories that are being spun around you, and you agree and go, okay, I'm okay. I'm sorry for wasting your time, is what women tell me constantly. I'm sorry I've wasted your time. You haven't wasted my time. Just because we haven't got to that diagnosis in that minute doesn't mean you don't have one. And it's a really important kind of message I want women to understand, that if you have gone to the A&E department with something that felt quite significantly like your heart, and you've left being told everything's fine, but you're not 100% sure of that explanation, that's where we come in. I cannot tell you how many times I've re-referred women to cardiologists because I've gone, you've not been investigated. This still sounds like your heart. That's not right. And the next drama is there's huge waits for these non-invasive tests that might get to the correct diagnosis in women. And those long waits are accepted because they haven't walked in with obstructive disease. But just because it's not a big obstruction doesn't mean it couldn't strike again, as she could drop dead. Her presentation of heart disease could be dropping dead. And that's really sad, and I've seen it.
Yes, it's a quite significant presentation, really, isn't it? That's not the kind of presentation you'd really like. But
No.
On a scale of 1 to 10, I'm putting that at 10. I don't want it. Maybe even 11.
100%.
I've told you my rosacea blood pressure story, haven't I? Have I told you that story?
I don't know. No, tell me.
All right. Well, this is a classic example. I'm sorry if people have heard this before. This is a classic example of being dismissed. So I have a very strong family history of strokes. Grandfather died of a stroke. Uncle died of a stroke. Father had a stroke, was left side paralyzed for the last 10, 15 years of his life, and then had another stroke and eventually died. And all of us have very high blood pressure. So one day I was sort of sitting here and I was thinking, this is during COVID, and I was thinking, I don't feel right. I felt kind of a bit dizzy and a bit sick. So I took my blood pressure. It was like 160 over 100 or something like that. And I thought, you know what?
That's
I'm just
high.
going to go to the hospital. Yeah. So I thought, I'm going to go up to the hospital. So by the time I got to the hospital, I nearly passed out at the front desk. So they sent me straight through to sort of sit in the corridor inside the other corridor. And while I was sitting there, I had a panic attack because I thought to myself, oh my God, I could actually end up like Dad now. This could. So, I could end up paralyzed or I could die. I'm in this hospital and I'm alone. And I had a panic attack, burst into tears, and I have rosacea. So I went bright red, which gave me that classic butterfly redness
Yeah.
across the cheek. So by the time they wheeled me around, they thought I was an alcoholic. And
Oh
the
no.
whole time I was there, all the conversations we had, even when my blood pressure was up to 185 over 120, all of the conversation was about my alcohol intake. And in the end, I just sort of sat back and I just kind of thought, you know what, I'm just going to let this play out. One guy even because I was across the front desk, he got he had his documents in and said, what's happening at bed 18? And they said, oh, we're waiting for somebody to do whatever it was. And he threw his papers down on the desk and went, what a waste of money. And so I was just sitting there going, this is great. By the time I left, they actually, my face had calmed down and the doctor would come up to say, oh, yeah, you're right. Your face has gone back to normal now. But here you are. Here's a script for thiamine. I had no advice on my blood pressure
Wow.
whatsoever. I was given a script for thiamine, which is a B group.
It's a vitamin B supplement for people who drink too much.
For people who drink too much.
Oh, babe.
Yeah.
Do you know what, right? It's funny, but not funny, right? Because you're there going, you've gone in really stressed and worried about something with a really valid family history and concern. And malignant hypertension is when our blood pressure is so high, it's dangerous. And sometimes even as GPs, we'll go, look, I can't even treat this today. I'm too nervous. I'm actually just going to send you in because I want someone to monitor you.
Mm.
By
the way, this is while I was on blood pressure tablets.
So it's really important, I think, that anyone listening listens to this. Is a common issue. I don't want us to have chips on our shoulders necessarily, and I don't want you to go to medical settings with like an altercation attitude, but I think advocating for ourselves is really important. And for me, I am a miscommunicator, okay? It is so important to me that whomever I meet as a patient, I explain what's going on, what I think is going on, I might be wrong, but here's what we're going to do. And if I am wrong, this is what we're going to do. And do you understand the plan? Do you understand what is happening to you and what the next steps are? And we're saying today everything's okay with your heart because we've done X, Y, and Z to be confident. So if it happens again, this is what you need to do. And I just think that that basic level of explanation for most things is just unacceptable. It's just not being done. And I genuinely do think that people now are walking in and out of the emergency room just going, well, I feel really bad. I'm going to go. Oh, they sent me home, so I must be fine.
And that's a really missed opportunity.
And I think it's that belief. Everyone's bias is to be well. So if you've been told you've not got cardiac chest pain, you're a bit relieved. And you will then go, okay, well, I guess I'm making this up. So I won't tell anyone the next time it happens.
No.
Because last time I did tell them, I went to the hospital and they told me it was fine. And that's another problem, I think, with women especially, in that if you're not getting the classic chest pain, heavy chest, squeezing, feeling out of breath, spreading to the jaw and left arm. We all hear about, oh, is it going down the left arm? If you're just getting a little bit breathless, a little bit panicky, and you just kind of feel not quite right, you're going to start making a story up. You'll tell yourself a new narrative as to why do I feel this way.
Yeah.
And I think that I can't say it enough, is the thing that we need to try and change within women. I think healthcare has a long way to go with regards to how we approach women and cardiac issues. But I think as women ourselves, we need to start going, actually, heart disease kills women. I'm a woman. Is this my heart? And so we're thinking chest pain, nausea, unexplained, breathlessness that's unexplained, aches and pains across the chest that are unexplained. You're starting to go, well, feeling out of breath upon movement. That's new. So if you've gained weight and you've got a bit unfit and you've generally felt your exercise tolerance is low, that's one thing. But saying, do you know what? 2 weeks ago, I could go up my stairs. What happened? Big changes, stepwise changes in your function. You need to be questioning, what is that about? And then there's the other bit as well, Fiona, what's the background? Do they have an autoimmune disease? People who are more inflamed because of disease are more likely to have cardiovascular problems. So a lot of women have basic things, thyroid disease, lupus, rheumatoid arthritis. These conditions will increase her lifetime risk of a heart problem. All the more reason to be going, what are my numbers doing? What's my blood pressure? When was the last time someone did that? When was the last time someone talked to me about my cardiovascular health? And so again, it's trying to get us into that mindset of the heart is the key. It's our pump. Nothing works without it. So, you need your pump and I can't replace it. So if there's something wrong with it, that's a problem. I've got to tinker with it and I've got to support it. And that's where the kind of doing everything as best we can comes in, the eating well, sleeping well, moving well, resting well, kind of calming our cortisol levels, improving our sleep. Our weight goes up when we don't sleep because our hunger hormones spike. That's a problem. We start to gain weight, our estrogen drops, our blood pressure goes up, our inflammation goes up. So you can see how throughout perimenopause, just all by ourselves, our heart disease risk is slowly increasing. And our stroke risk, because you brought it up, it does increase with age. So we do talk a lot about HRT and actually whether it's safe now in the over 60-year-old women, or if you've gone over a decade from that final menstrual period. We are no longer saying that we're panicked about that woman having a stroke if we talk about HRT, but that woman's risk of stroke goes up just because she's getting older. And there are other risk factors for strokes, like having diabetes or fatty liver disease or being more inflamed or smoking. So not only is age a risk factor for stroke, but women may have these other conditions. So all I would just say, if we're thinking about that, is HRT is not a no, but it's still a nuanced discussion. If you're over 60 or you've gone over 10 years from that final period, we still need to just have a think about what's right for you and whether or not it's safe. But we're not anymore saying we think, God forbid, like you're going to have a stroke if we start it. There was definitely some thinking around that we were concerned about that, where we're not now. But our stroke risk does go up with age, and we can't get away from getting old, which is really upsetting, but we can't.
That's true. That is very, very true, as much as we would like to try. So not only do we have Minoka, we also have Anoka and Inoka. So
Yep.
what are they and how do they present and how would
Okay.
people know them? And then I guess the other point too actually is once you've gone through those, just so I remember, is that, you know, if we're having those things, we do turn up at the hospital and nothing shows, how do we actually say to them, you know what, I think, you know, we need to investigate this further? How do you actually say that to
Okay.
someone who said you're okay?
So let's do the acronyms. So Inoka and Anoka are kind of an umbrella. They're under the same umbrella. So Anoka is angina um, without coronary obstructive disease, and Inoka is ischemia in the absence of obstructive disease. So it's
Where
similar.
angina means
So
pain and ischemia
angina
means
is
blood supply.
I think of the way I describe angina is effectively the blood flow with oxygen is not getting around the heart. And then the question is why? Is it because of spasm or is it because of blockage? So you've got a blood vessel that's carrying all the nice oxygen blood cells through. If it's not getting through, there's either a great big blockage or it's spasming, and therefore it's really hard for the blood cells with the oxygen to get through. So ischemia with non-obstructive coronary arteries in occur is effectively us going, if we put an angiogram catheter all the way through into your groin, up into your heart, we wouldn't see a great big fat plaque blocking everything that we could remove and fix. You wouldn't get this great big boulder in the road. What we're seeing is that we're not seeing this great big blockage. It's like less than 50% blocked. We're going, right, you're presenting with symptoms as if you've got ischemia. We're seeing perhaps even ECG changes. ECGs are what you can get done at most GP practices. You put little electrodes on your chest. It gives us a snapshot, a photograph of the electrical rhythm of a woman's heart or a man's heart. And we sometimes see that electrical image, that snapshot in time, looks a bit strained and stressed. And that might make us go, okay, what the heck's going on here? But sometimes that can look normal because it doesn't change until the stress is there, and we may not be with you in the moment when the stress is there. So with Anoka and Inoka, effectively, this is us saying women have microvascular disease. They don't always have a myocardial infarction, meaning an MI is a heart attack. So with Minoka, that woman's had a proven heart attack. We've proven it because she's had this blood test where we see troponin rise because the heart throws it out when there's stress and damage. And then we're looking at to why that's happened. Whereas with the others, Inoka and Anoka, she's not had a heart attack. So she's got symptoms of ischemic heart disease. She's got heart disease symptoms. But to diagnose it, you've got to do some testing. So a lot of women have these symptoms. They will present with maybe chest tightness, palpitations, symptoms that are transient. They come and go. It stops her in her tracks, perhaps. And then it passes. And then she goes to her doctor and they do an ECG. It's normal. And they do a cholesterol, it's all right, nothing exciting, not going to talk about starting statins and things. And then the
Keep
issue,
going for 1 second while I put the dog away. You just keep going. She's going to bark.
yeah, then the issue really is at that point, whether or not a cardiology referral is considered. So again, not every woman, girls, who presents with a heart type symptom or a palpitation is going to get referred to a cardiologist. But we're starting to look at pattern recognition, look at how often you're presenting, what are your risk factors, what's your family risk factor. So what I was saying, Fiona, is it's not like you present with one or two, you turn up and say, I've had some chest tightness and I send you to a cardiologist. It's actually all about, well, how often has that happened? What's her history? What's her story? What's her family history? What are her numbers doing? How suspicious am I that she needs cardiac investigation? And you might say, okay, we do a thorough MOT, let's see what happens. She turns up again. All right. I'm like, okay, well, do I have any other really good explanation for her symptom? Can I plausibly explain it? Or am I starting to think this woman might have Anoka or Inoka? She needs cardiac investigation. She at the moment, annoyingly in the NHS, she needs a cardiologist because I can't request the test directly as a GP. That she might need to look into this further. And I want women to understand that you don't get diagnosed with coronary artery disease at crisis. That's not great. That's not the aim. The aim is not to get the diagnosis like your first heart attack. Just like the aim is not to get the diagnosis of osteoporosis when you break your bones, right? I'm a bit obsessed with bones, as you know. It's like we want to pick this up before it goes wrong. And so again, Fiona, what I'd say is if you are worried, it's a conversation. Do you think I need to see a cardiologist? And obviously in the private sector, it's really different, right? It depends if people are fortunate, have means to go and investigate themselves privately. But within the NHS situation, I think it's always that conversation. Do you think I need to see a cardiologist? Do you think you could ask them for advice? It's how do we go about moving this on? And I think what I would say to clinicians watching is to have a very high suspicion index for those women. I'm really thinking about my 50, 55-year-old women, they're post-menopause, and then very few women, Fiona, turn up pristine. And what I mean is never having smoked, never having drunk, doing all the weight training, being perfect, like eating protein, doing everything as perfectly as possible. Most women have a story and a bit of genetics that complicates and muddies the water. So you need to be thinking about investigating her.
Yeah, especially since it is the biggest killer of women. It's not a surprise. You mentioned very briefly, and somebody's asked you about lipoprotein A. Now, I believe that there's an argument that the European, I think, I can't remember their name now, but they did a paper saying that this is something that should be checked more than once in a woman's life. Are we
okay? So it's more accurate than just checking your LDL-C, which is what we're checking in the NHS. We're checking your LDL, your HDL, cholesterol ratio, your triglycerides. So let me just take LDL. So when you check LDL cholesterol, what you're doing, when we measure it, we tell you this is your LDL. Okay, we give you a number. What it is, it's the cholesterol that the LDL particle is carrying. That's what you're measuring. With the apolipoprotein, what you're actually measuring is like the actual particles of bad fat. So the LDL, the VLDL, it measures a whole group of the simplest way of thinking about it is bad fats, but the actual numbers of it. You're not just measuring what the little LDL particle is carrying. So you're actually measuring the numbers of bad particles. It's more accurate. It's more accurate if you're a moderate to high risk patient. It's more accurate because sometimes people with high triglycerides for other familial reasons, we get this kind of skewed, kind of confused picture sometimes where when you measure LDL, it's not very accurate if you're somebody with high triglycerides. So the truth is lipoprotein is more accurate. You're not going to get it straightforward in the NHS at the moment. In the private sector, you can get it done. What I would say to you, though, is if I'm really honest, if you're thinking about spending your actual hard-earned cash, is that if you're a low-risk woman, it's not really essential because actually what I want to know is what your basic levels of LDL, HDL, cholesterol, triglycerides are. I want to know if you've got insulin resistance. That's checking your HbA1c, looking for type 2 diabetes. And the main conversation I'm having with any woman I'm meeting when I'm thinking about her whole health is the basics. Is she sleeping well? Is she moving well? Is she eating well? And is she resting well? And when I say resting well, what I mean is what is she doing to reduce her stress? What turns on her parasympathetic nervous system? What makes her feel good? Because that's going to reduce her chronic inflammation levels. And so with any woman in that first conversation, you can get really bogged down by the numbers. But the truth is, if you're getting your LDL measured and you're in your 50s, and we're looking at something called Q-risk-3 when we're working out whether or not we think maybe cholesterol supporting medication like a statin might be helpful, to be honest, you're not going to get that much more information from doing the more expensive test if you're a low risk woman. If you're a high risk patient, it's a completely different conversation. So it's a bit nuanced. And many women, just so you understand, when they first show up with their kind of changes in cholesterol and fat levels in menopause, don't necessarily meet the threshold to have a conversation about statins. But that doesn't mean you shouldn't be eating well, moving well, sleeping well, right? You still need to be doing all those things. So if we're starting to talk about statins, it means we've reached a point where things have got worse. And so the aim is always not to kind of go, well, I'll change my lifestyle when you tell me to.
Yeah.
Because then you've already got some heart damage and I can't undo it.
You mentioned the word statins there, and this is a contentious issue at the moment.
I know.
A very large social media group of people saying statins don't work. And I even went to a corporate event a while back where they were talking about, new frontiers in women's health and pushing the corporate sort of side of women's health. And the woman who was introducing it said, and statins don't work. And I was like, whoa, hang on a second. So what
Okay.
is there a point then that, perhaps with the microvascular stuff that they don't work particularly as well, but for the macro stuff
All
they
right.
do?
So,
What's going on?
okay. So remember, my disclaimer here, guys, is I'm not a cardiologist. I am a GP of 20 years, and I definitely meet Joe blogs on the street and Miss, Josephine average, and I see lots of patients. I've been working a long time. So there's primary and secondary prevention. So let's just for one sentence. Secondary prevention is you've had a heart attack. I've proven it. I know you've had it. Being on a statin prolongs your life. Full stop. Let's think about primary prevention. So this is you've never had a heart attack or a stroke. And so I'm going, will giving you this drug contribute to a lifetime risk reduction in a heart attack or a stroke? It will lower your cholesterol because that's what it's designed to do. But to some extent, okay, well, do we care? The question is, am I going to live longer if you give it to me? Because if you tell me you're going to lower my cholesterol if I take this drug, but it does nothing for my, lifespan, then why am I taking it? And so this is where the kind of evidence, I think, it gets to the point where we do know that if we treat a group of people in primary prevention, which means you have reached a point where we've done a cardiovascular risk score on you. We've taken into consideration your age, your sex, your family history, your medical history, your blood pressure, your ratios of good to bad cholesterol, a whole host of stuff. Do you smoke? What's your weight? What's your height? Taking all that into consideration, and I'm working out your 10-year risk of having a problem. We know that if we reduce your LDL by 1 millimole per liter, I reduce your risks by about, let's say, 25%. Meaning, if I give you a drug that makes that number lower, your risks of an event do go down. It doesn't mean you're never going to have an event, because remember, there's this complicated bag of reasons why an event might happen, and menopause is one of them, right? And so in primary prevention, the challenges we have is we have to treat 150 people to prevent a single problem. So you're starting to have to treat large scale groups of patients to start seeing long-term benefit. But then you always have to look at your own benefit. And you might say, can I reduce that LDL level with diet? Can I reduce my stress? Can I reduce my inflammation levels? Can I reduce my weight? Will that see a reduction? And so what I say to people with primary prevention is a statin is one piece of a puzzle. And there is a great big puzzle that when I click it all together, we're talking about heart disease, long-term heart health, stroke prevention, heart disease prevention. And so for me, a statin is one piece of that puzzle. It's not a silver bullet. So again, if the statin's it's not gonna on its own save your life. And so I think what I would say is, that's my best answer. Do they single-handedly prevent heart attacks and strokes? No, of course not. Nothing single-handedly can do that. But do they help? Yeah, they can. But then you've got the challenges, right? Any drug I give you has a side effect. About 10 to 15% of patients, they get muscle aches. And that's a problem because we're already achy. So we've got the musculoskeletal syndrome of menopause that are happening to us. And we're already a bit achy and tired and we want to exercise. If I give you a drug to prevent a problem that may never happen to you, and as a result of that drug, you tell me I can't exercise, well, I'm going to say, well, that's worse. Right? You not exercising is worse for your heart, so stop the drug. Let's look at this. So it's always about a conversation, a balance of discussion about what's right for you and why is it right for you. If I give it to you and I upset your liver, well, I don't want to give you a liver problem. We have to check your liver function before we start it 3 months later. We've got to do it yearly. If we're upsetting your liver, we're not going to carry it on. That's not in your best interests. So I think there is a conversation to be had. If you reach a threshold where statins are something we're going to talk about. You asked specifically, does it help microvascular disease? And my answer to that is, has anyone studied it? And the reality is we are just not represented. So if you look at all the statin trials, it is not full of women. It's not full of menopausal women. And so the reality is we just, it's embarrassing. We just
It
don't
is
really
embarrassing.
know.
Exactly why I
It's
set up the Menopause
embarrassing.
Education Fund,
Half the
because these
sky
things just
got
aren't.
no medical study information on us. We're
Yeah,
half the sky. So it's a problem, but it will always be a conversation that I'll have. You know, I have no strong feelings about whether a woman should or shouldn't take a statin. My job is to go, here's the evidence I have. Here's the advice I have around all the things I need you to consider. The decision is yours. There's some decision aids out there. Nice, have a patient decision aid. It's quite wordy though, and if you've not got high reading age, it's not particularly useful. And so I think what I'd say to any woman is, let's not even worry about statins. I think worry number one is, have you thought about your heart health? And actually, doing your baseline levels sometimes is just nice to know where you are. If you're in your 50s, in your menopause, or you're in your 60s, and you think, I've been menopausal for a while, I would definitely encourage a health check. Go and just find out, are you insulin resistant? What's your numbers up to? Has anyone done your blood pressure? Has anyone measured your central? So I would argue I'm guilty of this. I don't often get my tape measure out in my consulting room in my NHS practice. This is like time, but
I
actually
can
that's a
tell you
really
now,
good
no one is
marker.
coming near me with the tape measure. I will
But actually, central adiposity, so measuring your fat around the middle, is a really accurate way of understanding visceral fat. There's fancy kind of weighing machines. I really want one in my private clinic. I'm saving up for one called an in-body scan, which can give you like a visceral fat score. It's really helpful for women to see it, to look at their fat and muscle distribution, so that when they start to make improvements, they can see those numbers going down. Visceral fat is not good. It's the bad fat wrapping around your organs. Your organs don't want to be covered in fat. And you can be a very skinny woman and
yes.
have a lot of visceral fat. So it's not, we're not talking about obese people necessarily. So we are all at risk, women, we are all at risk of having a redistribution of our fat to unhealthy areas. It's really annoying. And we annoyingly have to work harder to combat it.
Yeah. So take home messages out of that I'm getting, just tell me if I'm wrong, is basically, if you, and I base this on my husband basically, who literally had, I can't remember what his cholesterol was, but it was in the double figures and it wasn't pretty. So he started running again. He lost 18 kilos.
Wow.
He absolutely, changed his diet completely, because what I didn't know was when he was at work, he was sucking down packets of chips and things. So he stopped all of that, and then he went back and got his cholesterol measured again, and the LDL didn't change; it actually got worse. So he has been on statins for about the last 25 years or so. So
But
basically, my theory is this: if you do all the right things and nothing changes, then a statin is probably a reasonably good thing to sort of
absolutely. And lifestyle's always encouraged first. So we'll always say, go away and try this. But what I would say is the story with your husband is that what he's done by doing all of those things is he's reduced chronic inflammation. He's improved his autophagy, meaning the cleanup of his cells overnight are happier and get better. He's reduced his lifetime risk of dementia by doing that. We know that moderate exercise, regular basis, really improves our brain function. So always remember that even if I say at the end of the story, I still want to give you this drug, all that good work is about having a brilliant health span. To some extent, honestly, Fiona, I couldn't care less about people's lifespans, because if you're going to live in poor health, it's not worth it. But it's all about your health span. And so again, when we talk about statins, it's all about, you hear a lot about mortality. This will make you live longer. And I'll go, cool, I can give you this drug. And I'm going to tell you the study says it'll make you live longer. But if you don't do all this stuff, you're not going to be living well. And you want to live well.
That's what really worried me when I was in that thing, I'm thinking about Dad. He did not enjoy the last 15 years of his life. He was stuck in a bed, and it really wasn't good. There was a point that I was going to come to out of that as well, and that was the other thing too, is also they're not relying on HRT as being your golden goose either.
It's not. It's part of the puzzle of midlife wellness and health. We know it protects the heart, and we know that it's not being recommended for cardiovascular disease prevention and disease prevention. And it's what I tell women is, I say, when we're having our consultations or our group menopause consults, what I'm saying to them is, look, you might choose it for symptoms, but you might choose it for some long-term health benefits. And here's what they are. So I can't tell you have to be on it, and some women can't have it or choose not to have it. It's complicated because of their cancer history. We know the stories. But if you're in a fortunate position where it is an option, you need to understand why you're going to choose it or not choose it. And if you're not going to choose it, then you also need to go, okay, well, I then need to be doing all these other things to mitigate my lifetime coronary artery disease risk. So how am I going to combat that? And don't get me wrong, even if we are on it, we should be doing all the other good stuff too. So it's just quite interesting. So I get a lot of women who just go, oh no, I don't want it. But it's like, that's cool. But I still, if you're going to come back to me in 10 years stressed out about your heart, then I'm going to say, this is what I need you to help me help you start to be thinking about and start to do.
Yeah.
And, you know, that I know life's hard and busy and everyone's got a lot on, but it's so essential that we consider how we are going to be, you know, as we progress through menopause and as our estrogen drops, you know, we reach that point in midlife where if you're looking at the next 50, which is how I look at women, I'm looking at the next 10, 20, 50, how am I going to help her live well? How am I going to help her bones, her heart, her everything? Then it's about understanding that, you know, even if you say no to the drug, it's okay, cool, but let's look at what you need to do. And it is a lot.
It is a lot. Here's a left of field thing, because like this sort of hangs around in the back of my mind all the time, and that is that, okay, if erectile dysfunction is a precursor to heart disease in men, why are we not looking at vaginal atrophy or genital syndrome of menopause in the same way?
That's really true. So there was a huge study that was released earlier this year around sepsis. Women who are not using local vaginal estrogen products basically die of sepsis, urinary sepsis, compared to the counterpart women who are using local vaginal estrogen. Local vaginal estrogen, for me, is a no-brainer. If you meet me in life, in my clinic, you'll get given it. You'll know all about it. My patients know all about it. Because I'm like, you need this, even if you think you don't need it. Let's talk about it. So, you know, women die less if they use local vaginal estrogen. Now, we don't really have an association between female sexual dysfunction and mortality as such, as far as I know. But, you know, a lot of these things, Fiona, I would just say is like, you know, if we had a big statement that said men are misdiagnosed when they go to A&E with heart problems, men are not taken seriously, men are gaslit, do you think that'd be bloody international news? It would be, you know, government agenda, you know, Trump would be all over it. So it's like, I think we are where we are. And I you know, I think just to throw a little bit in at last minute, really, just around kind of, you know, women and heart disease. We said we promised a moment on GLP-1s, and I know a lot of my patients.
Sorry, I completely forgot.
Yeah,
yes,
a lot of my patients are using them. And what I would say again, just around that is, you know, as we have been discussing, we gain weight, and there are lots of reasons why we gain weight. Losing weight will help your heart. So I kind of just wanted to throw that in as well. So if you are thinking about your heart health and actually weight loss as part of that consideration, then, you know, weight loss drugs on the market do exist. It's complicated to access them in the NHS, etc., but a lot of people are buying them. And so they can reduce your chronic inflammation levels, they can reduce your weight, but women, be wary. They also reduce your lean mass, your muscle mass. And our muscle mass peaks at around 30 and then declines for men and women, and ours declines more rapidly when we hit menopause. If you're quite obese and you lose a lot of weight with, let's say, Mounjaro, then relative to your fat loss, your muscle mass will have gone down, but actually it would have gone up a bit because you've lost so much fat. So actually the first commitment to the weight loss injection is not the end of the world. The issue we're seeing as doctors and clinicians is the multiple users. I've used it for 2 years, 2 years ago. I lost loads of weight, gained weight. I'm using it again. And then they're going up and down, the repeated users. What's happening to those women is their muscle mass takes a hit the first time, but we're all right with it because they lost a lot of fat. But then it takes a hit, and then it takes a hit. And that's something called sarcopenia. So you've got to be wary if you're a woman in midlife using weight loss injections. My advice is make sure you are considering your nutrition and your resistance training. We know that resistance training is good for bones. You know, that we know that weight training is really important. And if you're not buying into moving in a certain way and considering high, good quality nutrition, thinking about your protein intakes, not the be all and the end all, but fiber as well. But if you're not doing that, you are going to get into trouble. You're going to break a bone. You're going to turn up. I'm going to talk about osteoporosis. You're not going to live in good health. So you'll be thin, but you'll be living in bad health. So remember, get strong, don't get skinny. But if you're trying to get thin, then just be really mindful with those injections that you're thinking about your future health, not just the weight loss that's happening, which is wonderful. If you've really, for many patients, this is a game changer. But for lots of patients, they're repeatedly using them now. What I mean is they're using them, they take a year's break, they use them again, take a year off, use them again. That's where we're seeing problems.
Yeah, it's because I was looking before just at a quick study that basically said that they're showing for people with type 2 diabetes, at least anyway. So I don't know if this goes across the whole board, but they are quite instrumental in bringing down the blood pressure, bringing down all the anti-inflammatory,
your cholesterol. You'll have less visceral fat.
Yeah,
it's a winner chicken dinner. I mean, it is amazing, providing you don't get big side effects or problems. But it is gonna be a big problem if people don't make the lifestyle changes that need to be made to sustain it. So we're going to see people using it in their 30s, using it in their 40s, using it in their 50s, and then boom, menopause hits, and then boom, their bones are quite thin, and they've lost muscle mass, and they've never learned how to eat properly, and they will be thin, but still have heart disease and problems. Because chronic inflammation is still a problem, because they're not necessarily fueling themselves in the right way. So just the weight loss is brilliant, and that initial weight loss can see a massive boost in all these great health benefits. But you've got to do it with that mindset of, how am I going to sustain this?
Yeah, absolutely. Lifestyle. It always comes down to lifestyle, really, doesn't it? Which is
yeah, it does. It does, and that's the easy to say but hard to do. And I share my anecdotes with my patients all the time. Good days and bad days, right? But it's just getting up and trying again. It's just knowing every day can't be perfect.
Yeah, true, exactly. And I know that you'll be thinking, it means that I've suddenly got to get down to the gym and I've got to be lifting, 30 kilos and a half marathon. I mean, just being just a bit more.
Literally, stand at your desk and do some air squats. It's free. There's so much you can do without having to spend a penny, join anything, or buy a subscription. And again, if you've ever been in my consulting room, I'll get on the floor and show you what to do. So I have no issues going, right, let's do this together. I show you that you can do it. And it's really easy. So in the sense that, what fuels me is going, hey, let's make this so accessible and so straightforward that anyone can access it. And it's the motivation, it's the drive, it's the accountability, it's texting your mate going, it's time to do our plank for 1 minute, or whatever it might be. So we can do it. I promise. You don't have to spend a penny.
You just told us what your next round of social media posts will be, what you show in your office.
No problem. Keep my weighted vest on the door.
Exactly. Yes. Although I have lots of arguments with people about weighted vests, because I think
it's difficult. I think the reality is, if you're a bit thin, the weight helps. If you're a bit fat, you probably don't need it. And I think, jumping up and down at least 50 times a day is probably a good idea. The problem is we're leaky ladies, and sometimes that's in itself an issue. But I think it's any movement is good. So even if the movement's not building your bone, it's helping your brain function, it's helping your cellular function. Walking regularly throughout the week helps your brain. So any movement is good.
I got somebody that's asking, how can I share this on to non-LinkedIn users? It will save to YouTube after this, fingers crossed, if it does, and then on both the Hardest Written Forum and the Menopause Research and Education Fund channels, and then you can just grab the link and share it easily. If people want to find you, which I'm sure that they will want to, so that they can be tortured in your office and shown how to exercise, where do they find you?
I am at womenswellnessclinic.co.uk. We have an Instagram page at Women's Wellness Clinic Doctors, and a TikTok account at Reem Al Shaikh, Dr. Reem Al Shaikh. But NHS, you'll find me registered on the British Menopause Society website. But we're off for face-to-face appointments. We're also online, so wherever you are, you can access us. We're happy to chat with you, video you, whatever it might be, or come visit us in Cambridge and Bishop Stortford and Ware.
Oh, that's good. I didn't know you did online stuff as well. That's great.
Yeah, we do. It's really interesting. Women like to come, but yeah, I do some video consulting. Put it this way, I think for many women, if you just need to get started, and then we'll figure out the next thing. And that's why I like the videoing or the phoning, whatever women prefer. Just getting going. Just got to get started, and sometimes that helps. wherever you are.
Yeah, no matter how painful it is. True. Brilliant. All right, my love, I will let you go. And thank
Thanks.
you. And yes, it should save to the Instagram now, it should save to the LinkedIn, it should save to the YouTube, it should sort of save everywhere, I hope. But if not, I'll have it somewhere. Thank you, and we will talk again soon.
Cool. Thanks a lot.